All right, excellent. We'll get started for the sake of time. Good afternoon, everyone, and good morning if you're on the other side of the world. It's my pleasure to introduce this session on uveitis case presentations. And my name is Ahmed Salam. I work at the University of Arkansas for Medical Sciences, USA. So we have excellent guest speakers telling us about mystery case in uveitis, and we'll get started with our first speaker, and that would be Professor Hasna Lamari from Morocco.
Thank you very much for the invitation. Ankylosing spondylitis is a chronic inflammation disease involving sacroiliac joints and the spine. It can be actually B27 positive or negative. The most common ocular manifestation is anterior uveitis, 30 to 40%. The posterior segment manifestation is less found, usually associated with anterior uveitis. And I will report a case of isolated vasculitis in ankylosing spondylitis. My patient is 31 years old, followed for 6 years for ankylosing spondylitis and methotrexate. She was actually B27 positive and disabling right sacroiliitis with cervical stiffness. She was under Embrel since 18 months. I see her 2 times for 2 episodes of anterior uveitis treated by topical steroids. And she was referred by her ophthalmologist for decreased visual acuity of her left eye. The visual acuity was very low in the left eye, 110, and the anterior segment was normal, no uveitis, no anterior uveitis, and this is the fundus of the right eye. It's normal, and angiography also is normal. And this is the found eye of the left eye. And we see very extensive vasculitis with hemorrhage and papilledema. The angiography confirmed the vasculitis and show leakage of the papilledema. The vasculitis was very extensive, and all the vessels or the zones of the retina was touched. OCT show macular edema and papilledema of the left eye. So what is the diagnosis? We have vasculitis, unilateral vasculitis associated with ankylosing spondylitis without anterior uveitis, and usually we found anterior uveitis in AS. So we make a very big investigation. The inflammatory blood work was normal, sedimentation rates normal, CBC normal, CRP normal. Negative infectious screening, we search syphilis, we search tuberculosis, CMV, VIH, and all the infections can make this vasculitis. So because the screening was negative for infection, we put the patient under bolus of corticoids for 3 days with oral relay by 60 milligrams a day. And I see her 14 days after with a very good evolution. We see marked improved of the A fundus with the increase of the visual acuity of the left eye. Angiography show also net improvements. The OCT is normal, and retinal vasculitis is very rare in AS. We must eliminate other etiologies, especially tuberculosis in our context, because the patient is on corticosteroids or immunosuppressant. The treatment of the retinal vasculitis is based on corticosteroid bolus with oral or peribulbar relay. This paper say that posterior uveitis is rare, mainly dominated by Yalitis. This is a case report of retinal vasculitis with AS. It's a very rare association, and this other paper says that retinal vasculitis is rarely associated with ankylosing spondylitis, but we don't know the real frequency. I think it's underdiagnosis and underdiagnosed. There is not a special aspect, and sometimes can be occlusive. Optic disc staining or papilledema is frequent. This is a paper from Center Specialist on Uveitis, and he find a very high level of posterior involvement and peripheral vasculitis more than 30%. So they conclude that is we have that they have a high level of posterior uveitis because there is a systematic screening, including multimodal imaging, and posterior manifestation must be asserted, particularly if there is an anterior uveitis. The posterior ocular cell manifestation in patient-associated uveitis need most aggressive treatment and have a worse prognosis. These papers say that AS with HLA-B27 is associated to an increase of choroidal thickness, especially if there is an anterior uveitis or a systemic inflammation. The uveitis in AS increase risk of acute coronary syndrome and stroke. What about etanercept? It's a tumor necrosis factor. The studies demonstrate its efficacy in improving the inflammatory symptoms associated with the rheumatoid arthritis with minimally adverse effects. So we can ask two questions. Can etanercept treat uveitis, or can it induce uveitis? For the first question, the etanercept has not efficacy over placebo in preventing relapses of uveitis in patients. And for the second question, the answer is yes. Uveitis associated to etanercept is paradoxical. That means it's the first episode. Generally, in the first year, it's corticoresistant inflammation decreases only if etanercept is discontinued. So for our patient, we have two episodes of anterior uveitis. The retinal vasculitis is isolated without anterior uveitis. Etanercept is begun since 18 months. There is no systemic inflammation, there is no infection, and there is good and fast response to the corticoids. So can we conclude that the vasculitis is secondary to AS? Thank you for your attention.
Thank you so much, Dr. Hasna, Professor Hasna. It's fantastic. I was actually going to ask you about the Embrel, but you've nicely summarized this at the end. So I think the point from your talk is that with new imaging, 50% of patients with ankylosing spondylitis may have posterior segment disease. It just how severe is it to become clinically obvious, and also whether we're doing imaging enough in those patients or not, right?
Yes.
So if you have patients on Embrel, do you automatically advise, for example, let's say I have ankylosing spondylitis patients on Embrel, do you automatically advise change, or only if they are getting recurrent uveitis?
I think I work with a rheumatologist, and I see their patient regularly. We make work when I was in the hospital about interferon complication, and since this time I ask her to send me their patients, not only if they have uveitis.
Right, but unless they are having recurrent uveitis on the embryo, you would not advise like changing the medicine, right?
It's the first case which I see, but I have a patient who has tuberculosis, tuberculosis after taking embryo.
Right. Because we have a good number of patients here on Enbrel, and they have had ankylosing spondylitis in the past. But usually what I do is if they are not getting like repeated eye inflammation flare-up, I just leave them on the Enbrel. And I tell the patient and the doctor that maybe Enbrel is not the best medicine for the eye, but let's continue to see what happens. We have a good number of patients on them. That's interesting.
Dr. Salem, may I ask you, it's Dina here.
Please, yes. So yes, welcome.
Thank you for the invitation, and thank you, Dr. Hasnain, for your very enlightening case. Now I'm thinking, should I get OCT and possibly OCTA on the patients with recurrent or severe HLA B27 related uveitis? Would you recommend that? Would you recommend changing the screening for those patients with going to multimodal imaging?
Professor Hasna? Yeah.
Yes, I think when we have anterior uveitis, we must check the posterior segment. It's obligatory, and we must do also angiography for peripheral vascular, which is it's not seen in the ophthalmic exam. And OCT must be done because all uveitis can be complicated by macular edema, by cystoid macular edema.
Absolutely, that's a great take home. Thank you, Dr. Hasnain. Thank you very much.
Yes, I agree. I think there are great take-home messages from Dr. Hasna, Professor Hasna's presentation. One about the Enbrel, and it's good to just be aware that Enbrel does not treat uveitis well for some reason. We don't know if it's the attachment of the Enbrel to the TNF is not as solid as the attachment, for example, of Humira to the TNF. So then the TNF falls off and it releases, and then the TNF is released, and that causes inflammation. But if this is the case, why does it work for joint disease? Or it's the type of receptors they are working on. So it's not clear, but it doesn't work for uveitis, and it even may cause paradoxical uveitis, just for people to be aware. And I think the second take-home note is that 50% of patients with ankylosing spondylitis may have some perceived segment disease, vasculitis, or choroidal thickness, and at some time that might be very significant and require treatment. So it's a great point to take home. So, Professor Hasna, in the context for people following us who are into general ophthalmology or interested in the differential diagnosis, so what would be your main differential diagnosis in a case like this with ischemic vasculitis?
If my patient don't have ischemic right. vasculitis, but we can have ischemic vasculitis. This time we must complete with the laser photocoagulation and to reinforce the corticosteroids.
Okay, yeah. Sorry for that. Yeah, non-ischemic vascular. So, would you think Behçet, especially in your part of the world, in the Middle East, would be one of the top differential diagnoses in your case?
I don't understand what you.
Would Behçet be an important differential diagnosis? Behçet disease, Behçet.
Behçet, no, she don't have Behçet disease. She have very specific joints lesion. Spondylolisthesis is very net in the eye MRI. So
you exclude Behçet based on
when we have When we have ischemic vasculitis, we search for tuberculosis in our context, and we look for BSET. It's sure we have a lot of patients who have BSET.
Okay, excellent. All right. Well, thank you so much, Professor Hasna. And now our next speaker is Dr. Dina Badar, who's a uveitis and medical retina specialist in Cairo as well. Dina, thank you so much for being with us here. Please go ahead.
Thank you very much for the invitation. I will start sharing my screen. All right, can you see my screen?
Yes.
All right, very good. Okay. All right. Okay, so as my title says, I'm presenting a barn of varicella. So this is a 38-year-old seemingly healthy male patient who comes in for a second opinion regarding his floaters and drop of vision in the right eye mainly, but and he's also suffered binocular diplopia 20 days before the ocular symptoms. He had the referring doctor had already ordered serum immunoglobulin levels for viruses and a prescription of valganciclovir. So these are the images of the back of his eye in both eyes. Now we can appreciate that though the vision is still intact. So we're looking at 0.8 and 1.0 in the left eye, some AC cell, but also there are multiple retinal lesions in the periphery in both eyes associated with some vasculitis and possibly a confluence in the left eye. So what I do now, because we don't have ICG, is that I use the multicolor imaging for looking at the choroid and the retina. So if I choose the green channel, is 100% green image, I can appreciate the retina better. And if I use the red channel, I can see the choroid better. So we can see that the lesions are mostly retinal and that the vasculitis is well demonstrated on the green channel. What I also do is that I, those heat maps, for the thickness maps on the OCT, they showed vasculitis in both eyes pretty extensively in the macula. The OCT-B scan, can you see it or I need to hide it? Okay, I don't need to hide this. Okay. All right, so the OCT-B scans, you can see the amount of cell in the hyaloid, but not a lot of inflammation affecting the macula, and that's why the vision is still okay. But now, this is something that I do, and we do our images ourselves in Egypt, is that I scan the lesions in order to understand more about the pathology. So as you can see, the pathology here is mostly retinal. There's, yes, thickening of the underlying choroid, but the RPE is more or less spared, more or less intact. So we're looking at a lesion that is retinal with a lot of vitreous cell actually overlying the lesion. So I do my regular workup. I do the baseline. The already patient had the serum viral levels ordered. I do the ACE and quantiferin TB, and I do the CT chest, and the patient had already had the prescription. So these are his results. The serum viral levels came back high positive for both VZV and CMV. He also had a CT chest that shows an enlarged thymus gland. Now, I'm an eye doctor. I don't know what to do with this info. So I referred him to the cardiothoracic surgery because this is viral retinitis and it's a very serious disease. I don't know if the patient is immunosuppressed or what's happening. So the patient comes back. He has not started treatment and the lesions are becoming more confluent and they're taking a circumferential spread, very typical of acute retinal necrosis, but I am still confused. Is this possibly VZV or CMV, which is something that, even if you're not a uveitis person, you can meet in everyday practice. So the patient finally started his valganciclovir. And we're still thinking, is this CMV or VZV? But actually, the lesions have responded quite well, and we can appreciate that the retinitis has reduced in size and is becoming more fibrous and less active. So we did the AC tap, and for that, we needed to schedule OR. And I know it's different in different parts of the world, but in Egypt here, I prefer to do them in an OR. So I tapped him, and I also injected ganciclovir. And finally, the viruses are back, and it's very similar to zoster, but the patient still did very well with valganciclovir. However, when I referred the patient to infectious disease, we agreed to shift the patient to Valtrex. And also with ultra-wide field imaging, we can appreciate that the patient had like hiding lesions in the nasal quadrant. They look like their borders are getting more well demarcated, and they are on their way to becoming better and more quiescent. But we started the Valtrex with liaison with the infectious disease. So the patient is now on 2 grams of valacyclovir TID, and we continue to do injections for the right eye because it augments the treatment, and the lesions have all subsided in the right eye. The left eye did not need any injections, only with systemic medications. The patient is not immunosuppressed. So the reason why I'm presenting this patient is to invite all the younger generations and everybody who's not a uveitis person to learn the features of infection easily with multimodal imaging and get the scans on the lesions themselves, which can tell us whether this is possibly toxo. This does not look like toxo. Is this retinal? Is this choroidal? It sort of narrows down the differential while you're in the clinic and talking to the patient about the possibility for his uveitis, right? And also take a prompt action. So you can, and I've learned this from Dr. Salem himself, like start antivirals, but also refer the patient to either infectious disease, cardiac surgery. It really depends on the workup of the patient and systemically how the patient looks. Like if you think your patient has HIV, work them up for HIV and refer them to your colleague. And also, I've gladly learned that valganciclovir does cover VZV infections, although we know that Valtrex is the mainstay for treatment of VZV. Thank you very much for your attention.
Thank you so much, Dina. This is a great case, and it opens the room for excellent discussion. So we had a similar situation where in the past, that again, the same confusion, and yes, it's good to know that valganciclovir does cover herpes simplex and herpes zoster as well as CMV, just as a toxic medicine. That's
I understand.
As well,
I fully understand. The patient has had the prescription. It's also for where I practice, it's very expensive, like seriously expensive, very hard to find, and patients pay out of pocket. But the patient has had already the treatment, and I was like, you know what? If you have it, if you're happy to start it, go ahead. Just a couple of days before we can get the tap and inject.
Yeah, no, I think great point. So, Professor Hasna, if you're still with us, can I just ask you, for the sake of the discussion, what would be your differential diagnosis in patients presenting with retinitis? So let's say we have a patient now presenting to you with retinitis, same age as Dr. Baddar's patient. How would you think of the differential diagnosis of retinitis?
We don't have a lot of CMV. I don't see, because there is another center who is specialist for this patient. But it's too difficult to find the treatment in our country for VIH patient. There are center for them, but for other patients, no.
Do you have access in Morocco to do viral PCR and toxoplasma PCR from the vitreous or from the AC?
Yes, we can do it. Yes.
Is that like simple to do in the clinic, or you have to take patients to operating room?
No, we can't do it in the clinic. We can do
You
it in
can
the
do it in
clinic.
the clinic. Okay. Yeah, that makes life easier, of course. Yes.
Only we must find a laboratory who can treat this.
Right.
Yes.
That's interesting. Okay, well, I have a case that may tie well with Dr. Dina's case, and then maybe after that we can have a discussion about the retinitis more. So I'll share
Great.
quickly here.
I know you like that kind of challenging case.
Yeah, no, it's actually it's interesting. It ties very nicely. So
I have one patient who has a very extensive occlusive retinitis and vasculitis, and all the investigation was negative. I don't find what is the problem. It's like CMV, but CMV was negative. He don't have VIH. He don't have anything. Only very extensive necrosis retinitis, and after. When I don't find anything, I make him boluses of corticoid with aspirin, and after he has a good evolution, make laser on the ischemic zones, and he comes with 110 for acuity, and now he's 1010, and this is I follow him for now since 8 or 9 years, and until now I don't know what he have. Perhaps herpes, perhaps I don't know.
that's interesting. Is he still on antiviral or?
Antiviral? Yes, I
Is
gave
he
him
still on?
antiviral.
Is he still on system?
No.
So maybe a good question. Yeah.
Only
Yeah. Go ahead.
aspirin.
Right. So maybe a good question to Dr. Dina before actually we move to the next presentation, since we have good time left. I think two questions, Dina. One is how long do you keep those patients on antiviral? And Valtrex 2 gram TID is a high dose. So you maintain the high dose for how long, and then how long do you keep them in general on the antiviral? And my second question is, do you use systemic steroids?
Very good questions. So the first question is, how long did we keep them? So I was working with infectious disease, and we decided, like, by the third week, all the edges of the lesions were gone, and also we were augmenting with intravitreal. So we dropped him to half the dose. We dropped him to the maintenance dose, which interestingly he was still on when he left, because he got a job in Saudi Arabia. And I was like, you know what? I don't want nothing happening to you when you're only starting work there. So he's a young chap, he needs his eyes. And interestingly, when we took down his antivirals, he started having some vitritis, some sort of, I would not call it immune recovery uveitis, but I think I would believe that this is like an autoimmune process rather than an infectious process. And I started using steroids on him because also he was developing some fibrosis at the place where the retinitis was. And I really wanted to reduce this as much as possible. I consulted with VR, and they said, you know what, let it sit there, just watch it. And so I put him on some steroids, reduced it, and then but I have not completely stopped. Like, I'm keeping him on maintenance dose, and he's now in Saudi.
And how long has he been on antiviral now, the Valtrex, like altogether? So months?
I want to say 2 to 3 months.
2 to 3 months. And what's the plan? Is to keep him for what's your usual in another patient who, for example?
No, I would stop. Like, I would watch them happily for I do, I do caryat on everybody, and I'd watch them for 3 months, and then I take them off, but bring them back on a schedule. Like,
yeah, I mean, I think in this particular case, it's interesting and a bit nerve-wracking because it was bilateral as well, right?
Yeah, and he was very young, and like some people may have something happening, and I didn't know. I personally don't know anything about thymus glands. Like, if you ask me, I don't know why this patient had large thymus, and it could be a sequestration site for his white blood cells, but his white blood count was okay. Is it related to the function? Is it related to him changing careers and moving? Did he have this flare of VZV? I still don't know.
Excellent. No, that's it's a great case, and I'm glad this patient did so well. Share my. Can you see my slide?
Yeah, perfect.
So this was one of our uveitis grand round cases, and my colleagues Eric Clegg, who was our resident at that time, he finished now. He just graduated, and Dr. Sanders was our current fellow, our previous fellow, and now graduated as well. So this is a patient who was hospitalized and was referred mainly to rule out fungal chorioretinitis because the patient had some eye. It wasn't really clear if she has some eye findings or not, but we were told to have a look on her. And usually we look at those patients not very urgently, especially if they are on antifungal medicine. But the story is this 27-year-old, she had AML, was after chemotherapy, and she went on to have bone marrow transplant. And she was admitted for a neurotrophic fever, and she was on lots of medications and was found to have candidemia, and there was no vision complaints. Although when we asked the patient, she said, actually, my vision is a bit blurred. Occasional headaches, joints pain. Otherwise, everything else is negative, and no other reported post-ocular history. And then this is her medical history. We know about the AML. We know that she had opportunistic infection. She had CMV viremia following the transplant that treated with antiviral. And she, of course, had the pancytopenia and electrolyte abnormalities. So nothing, she's married, single relationship, and no smoking. And she's, of course, on a list of medicines here. I'll point out the important medicines, which are the top one, acyclovir, is one of the important, I think we may need to know. And also letermovir, it's another antiviral here. And then she's on voriconazole at the bottom, as well as immunosuppression with tacrolimus. This is the situation here. Everything looks fine with the anterior segment and her vision. And these are her fundus pictures. So we said, fine, nothing really to do. I think it's not showing on that slide, but we show one area of cottonwool spot. And then because of that, which was not really shown in that picture, but we said, okay, we'll see it again in 2 weeks. So then she came back, and at that time she had fever and was readmitted, and now reporting significant blurring of vision. Her medicines are still the same. So she's antifungal, bacterial, and the medicines we talked about, the viruses. This is the situation now, 20/70 in the right eye with this visual field defect on confrontation. And that's the appearance now. So this is the right eye. We can see those lesions. So as Dr. Dina said, and again, Professor Hasna as well earlier, it's good to characterize the lesion as was done in both presentations. So we're trying to think of the lesion. This is again scanning over the macula and over the lesion to try to understand more about the lesion. And you can see here lots of things. You can see the macular edema, the subretinal fluid, the inflammation, and more important, the area of the problem, which is the retinitis here. And you can see the scleroidal inflammation as well, but the lesion is mainly of retinitis. And you can see that the retina is not only thickened, but it's also the boundaries are blurred, the layers are blurred. You cannot differentiate the layers. So the retina itself is inflamed. So we're dealing with retinochoroiditis here, which is bilateral in this patient. So that's the situation we're dealing with. And this is a big list here of differential diagnosis. So we like this way of classification: infection, inflammation, and masquerade. So infection, we go with bacterial, viral, fungal, protozoal. And with inflammation, we try to think what are the important diseases that cause retinitis in these patients. And the top one is, of course, Behçet. I mean, sarcoid can cause retinitis, but mainly it's choroidal rather than retinitis. But again, it can cause just retinitis as well. And then masquerades, we have leukemia and lymphoma, and this patient already had AML. And then, I mean, you can add vascular as well. So the retinal opacification or PAM with vascular occlusion. So the question is, in this patient, what to do? And this is the situation right now, and the patient has significant problems with the vision now. She has the right eye and left eye findings, so it's bilateral, but the right eye is the main area. This is the area there with hemorrhages, center involvement, and then you got the peripheral area as well. So I think one of the things to take home is always that in the context of retinitis, first thing you have to exclude infection before deciding that this is, for example, Behçet. And then at the end, especially if it's a patient, but not like this patient, if a patient who is fit and well, then you can think of lymphoma a bit later on, unless there are compelling signs from the beginning. But that's how I think about it. Okay, well, retinitis, this is mostly we're dealing with infection, unless it ends up being Behçet. So, and then infection, we go like, as we said, bacterial, viral, fungal, protozoa. So in this patient, I was thinking that this is virus, a bilateral disease, and the patient is immunosuppressed. One thing did not add up, that the patient was already on antiviral medicine. And I thought maybe she was on acyclovir, it's not that potent. But she was also on the other medicine, letermovir, which is a very potent antiviral medicine. So this is what we usually do in this situation. So we cover for viral. So we do intravitreal tap and inject. And we send AC tap or vitreous tap, depending on how things go, for viral PCR and toxoplasmosis. And then we check CD4 count to know just what's the situation of immunity for this patient. And we recommended at that point valacyclovir. But to be honest, at that point, I was not really knowing much about the letermovir and how potent is it. And the infection disease, we're saying it's very, very unlikely she's on potent antiviral medicine, but they went on with us with what we discussed. So here, and then this is her, the CD4 count was 15, so we know she has low count and probably low function as well, even sometimes more important. And her viral level PCR, where the viral PCR were negative for herpes simplex, herpes zoster, and CMV. So what are you thinking of now? And again, if we go to the list now, that list includes syphilis. It doesn't look like this. And we had bloods, and the bloods were negative for syphilis. So one thing to always think of is toxoplasma in immunosuppressed host, because it can
I'm
behave.
just going to ask you about the IUP.
About the toxoplasma.
The IUP, the pressure, the pressure.
Oh, the IOP, I think was fine. The intraocular pressure was fine. I can't recall it was high. So this patient had toxoplasma PCR, which again, in immunosuppressed host, I mean, this is the usual appearance of toxoplasma. It may even present with primary focal retinitis, even without a scar, but still in the posterior pole, and that's easy to diagnose. But we need to remember it may present in different ways, especially in immunosuppressed host. This is, for example, a patient of mine that presented who was immunosuppressed because of rheumatoid arthritis, immunosuppressive medicines, including methotrexate and steroids for a long time, and was presenting with this progressive retinitis, which heals then progresses, and ended up being not a viral retinitis, but toxoplasma retinitis. So I think this point takes us that toxoplasma can present like viral retinitis in the immunosuppressed host. Maybe I should have thought of it from the beginning, because the patient was already on antiviral medicine. So then the next one was like to think of was toxoplasma. But I just want to remind you again of this differential diagnosis. I think retinitis is an easy one. The reason is that it's usually infection, unless it ends up being like Behçet or lymphoma. So it's really easy one. It's you know that you're most likely dealing with infection when you have retinitis. I'll stop here, and we can maybe chat more about the retinitis and the differential diagnosis. Just get the Zoom. Sorry, Dina, do you have any other comments on this case or on retinitis?
Well, this case is very telling. Like, the patient is on antifungal, antiviral, and also, but she's also on tacrolimus, I believe. So she
was on tacrolimus, yes.
Markedly.
And she had significant chemotherapy before and bone marrow suppression. She's immunosuppressed.
Yeah.
So another question on these leukemia case lesions, because she had AML.
Yeah, so the lesions are very close to the vessel, which could be infiltrative. Like, you could think of infiltrative, but also toxo has an affinity to the vessels. So it's a very good case, and those cases, they're never straightforward, in my opinion. I think when you get those kind of retinitis patients, you need to sort of stop the clinic and give them a lot of thinking and time.
And Professor Hasna, any comments?
Immunosuppressive modified clinical the clinical symptoms. The inflammation is more or less than the normal persons.
Yes.
That's why we have only this. We don't have vitritis, and we have only the retinitis.
Yes, and I think that's why it makes toxoplasma present like viral retinitis. So it's bilateral and also multifocal, which is not very not the typical presentation of toxoplasma, which is usually a unilateral issue, at least at presentation, and unifocal, and more like in the posterior pole. So I think, as you say, yeah, of course, it's immunosuppression changes the presentation. We even had one patient who presented similarly, although it was unilateral, with aggressive toxoplasma and multifocal like viral retinitis. And that patient was 75-year-old. And that was reported as well, that even in elderly, for some reason, they get like some sort of immunosuppression of the T cell function. And it may present in a weird way. It may present like viral retinitis. Just being old can cause the toxoplasma to present like this. So something as well to take.
Yeah.
We had a case yesterday. Yeah. Sorry, go ahead.
I'm sorry. Do we have time for, can I?
Yes, we have a few more minutes. Yes.
Okay, so I was just gonna ask you, Dr. Hassan and Dr. Salim, about young patients that present with vascular occlusions. That is a vascular occlusion for like a coagulopathy, but they kind of look confusing as to being inflammatory. Do you see that in your practice? Like a 16-year-old with a vascular occlusion, and she's referred because they're thinking it's inflammatory, but in fact it's a hypercoagulability of the sort. Do you see that in your practice?
Yes, we see these patients, and sometimes they end up having antiphospholipid syndrome. Sometimes we don't have anything. I think it's sometimes difficult to differentiate between inflammation and just vascular occlusion, because with vascular occlusion, you also, have features of even sheathing. Sometimes they say continuous sheathing is more with like just vascular, while interrupted sheathing is more with inflammation. I think it's a difficult one to diagnose. But you're right, in this context, and maybe that extends the discussion that I was having with Professor Hasna, with occlusive vasculitis, and as she said, TB and Behçet disease are most important. Other causes includes, which we discussed some yesterday. Sorry, there's this. What's the syndrome that affects the ear and the brain?
Susac?
Yes, Susac as well. Yeah. Although that presents usually with a unifocal lesion rather than like a branch
arterial.
Yes, more arterial, more like a branch artery occlusion. And then syphilis and viral, they cause occlusive vasculitis as well, but they cause other things. So that they may cause retinitis in addition to the occlusive vasculitis. We had a case for
Yeah, go ahead, sir.
Please go ahead.
No, I'm good. I was just gonna ask Dr. Hasnan because she practices in.
Yes, Professor Hasnan, please go ahead.
And and how much do you see intermarriages and then inherited coagulopathies and inherited vascular diseases, collagen diseases? How much do you see? How often do you see this?
I have one patient with occlusive vasculitis, and he was treated as Behçet syndrome, and because his vasculitis relapses, we decide to give him TNF alpha, and we make check of tuberculosis, and we find that tuberculosis was quantiferon was positive. So we make him under preventive treatment of tuberculosis, and all the lesion, retinal lesion disappear. So it was tuberculosis uveitis. Yes, sometimes it's very difficult to know what is the diagnosis and what is the etiology of the vasculitis.
Yeah.
So that patient, you diagnose him mainly as TB or not Behçet, and did you maintain his immunosuppression as well as with the anti-TB treatment, or?
No, we give him in the beginning. We give him only preventive treatment, and then we give him a full treatment of tuberculosis, and all the lesions disappear.
And no immunosuppression.
No immunosuppressor, because he have many times immunosuppressor, and the uveitis relapse at every 3 months or every 6 months. Uveitis relapse. So after we give him the tuberculosis treatment, I never see him after.
Right. Yeah. So I think it's interesting. Behçet is very common in the Middle East, but it needs to be more of like a diagnosis of exclusion, right? Because you need to exclude other things. Because basically it's a clinical diagnosis, right? You have the picture in the eye as well as the systemic features, and more or less it's a clinical diagnosis.
In the tuberculosis?
No, Behçet. So what I'm saying is, how do you diagnose Behçet? I mean, for example, if we're teaching about how to make a diagnosis with confidence that this is a case of Behçet, what would you say, Professor Hasna?
For diagnosis of patient, it's a difficult question. We must ask the patient if they how it began, what is his environment, if he has someone in his family has tuberculosis or other infection. When he live, we find some uveitis similar to Lyme infection. We make a minimal. First, we make a minimal investigation to have to have an orientation. And if I work with the rheumatologist and with the internist, and we can find the most the minimal investigation to have a diagnosis. And sometimes clinically we can say this is HLA-B 27 uveitis, when the pain is very important, when there is a red eye and photophobia. It's easy to think to HLA-B Vincent, but when we have only some things like vitritis, vasculitis, it's difficult to find that etiology. And in the best center, only 60% of the uveitis have a diagnosis.
Yes, no, of course. I was just trying to, come up with a conclusion that maybe that, just be careful, and especially in the Middle East, Behçet is common, but be careful of things that can look like Behçet. Most important, because of the retinitis, make sure you're not misdiagnosing a viral retinitis as Behçet, because the treatment is very different and patients try to get worse. The other thing, like a case we saw yesterday from Egypt as well, was a syphilis patient that was diagnosed as Behçet and put on immunosuppression, just because syphilis is not common in Egypt and people are thinking more of Behçet. So I think just wait a little bit, investigate, at least exclude syphilis and TB. They should be easy to exclude by history and by test, and just think about viral retinitis. At least ask the question, is this a viral retinitis? So that's what I was. Pardon?
In uveitis, we must eliminate infection before treat the patient, because corticosteroid must be done in these cases without infectious treatment.
Yes, I think that's a great point. I think with this that can be like a great take-home message for the end of this talk. Dina, do you have anything else to add before we conclude?
Oh, thank you very much, Ahmed, for putting this together. And I've learned so much from the cases presented. And if you want me to say one comment about Behçet in Egypt, is that Behçet is never a slowly brewing disease. Like my experience with Behçet in Egypt is a very, very aggressive disease. Like the patient is usually has had a venous occlusion somewhere, post-phlebitic limb already, it's not an anterior non-granulomatous uveitis kind of disease.
That's a great point. I think that's why I just have a moment and think about like the other cause of retinitis, which are mainly infectious, before you conclude that this is syphilis, this is Behçet. I think if you miss, for example, HB27 disease with Behçet, treatment is more or less the same, but the problem is you don't want to miss syphilis or toxoplasma retinitis or viral retinitis for Behçet. Well, we're coming to the end of the talk, and I can see Dr. Mohammed here signaling the end of the talk. So thank you so much, Dr. Dina Badar from Egypt and Professor Hassan Al-Umari from Morocco. It was a great session, and thank you so much.
Thank you very much, Dr. Ahmed. Yeah, thanks a lot. Dr. Hassan, you can join in Hall B. They are waiting for you for the other sessions. Thank you, Dr. Dina. Nice to see you again. Dr. Ahmed, thanks a lot. Just an announce for all dear colleagues, in Hall A, there will be no session from 4 to 5 UAE time, so you can join Hall B. It will be a refractive session, interesting session with an eminent speaker, please. Thank you very much.
Thank you.